Hello, we are live, sir. We are live.
Okay, perfect. Perfect. Good evening, friends. Welcome to Indian Arthroscopy Society webinar, which is hosted by Indian Arthroscopy Society along with all of our friends from the SAARC countries. We have esteemed faculty from Sri Lanka, from Nepal, from Bangladesh, all of us, and Bhutan as well. We are missing Dr. Emal from Afghanistan. He had some emergency, couldn't join today. Maybe later in the day he would be able to join. This is second webinar in our series of SAARC cooperation. The first one we did with the knee as a focus issue. Today we are doing shoulder. And I am happy that we have the most senior faculty of arthroscopy and sports injuries from the SAARC nations available on the single platform today so as to share their opinions. Rajeev has been kind enough to arrange cooperation between the SAARC countries. May I just ask Rajeev to introduce faculty, and then we can start with our opening talk from Professor Pervez Hasan. So Rajeev, you first, please.
Thank you, IAS sir. So always guiding us and encouraging us to make meeting of neighborhood countries. And it was his dream only in last Indore IAS Con. He told that we should have some type of meeting, and because of COVID situation, the SAARC meeting in Bhutan was postponed. So I'd like to thank all the faculties from Bangladesh, Nepal, Bhutan, and Sri Lanka who have participated, because Emal, he is in COVID management team, so there was some issue, he could not join. He has some presidential meeting is there. So without wasting our time, just I would ask Dr. Pervez Hasan to start with his first talk, MRI reading of knee, shoulder.
Sure.
Yeah.
Rajeev, you can give the introduction.
Yes, Rajeev, go ahead.
Yeah. So we have Dr. Pervez Hasan from Bangladesh. Please, Pervez da, just and Dr. Hasan Masud from Bangladesh, and Dr. G.M.Jahangir Hossain from Bangladesh. We have Dr. Dilshan from Sri Lanka, Colombo. He has joined. He is an arthroscopy and trauma surgeon working in Colombo. We have Dr. Sonam Dorji, very senior orthopedic surgeon from Bhutan. He has joined. And we have our very good friend from Nepal, Dr. Rajeev Raj Mandar. So he is also Rajeev Raj. He is there.
Yeah.
Yes, I'm here, Dr. Rajeev. Hello.
From Kathmandu, Nepal.
Hello.
So over to you, Pervez da. Please start with your first talk.
Okay. Welcome to you all. Respected President IPS ORI, organizer Dr. Rajeev Ramon, friends from Nepal, Sri Lanka, Bhutan, and my dear colleagues from Bangladesh. The topic of my presentation is MRI of the shoulder. I will describe some basic things, not advanced, to understand the MRI. And if we understand the MRI in a nice way, we could give treatment, and of course, in a better way. First, we have to understand the signal. There are three types of signals in MRI. One is dark, one is intermediate, and is bright. There are three types of views: coronal view, sagittal view, and axial view. This is the picture of coronal view. So this is humerus, and this is the labrum. You can see the labrum. First, before going to in depth of the MRI, we have to know some basic anatomy of the shoulder joint. Anteriorly, the subscapularis, the above, there is a supraspinatus, and this is here is the biceps tendon, and posteriorly infraspinatus, and below is the teres minor. Now, we will describe some parts of the supraspinatus tendon. This is the footprint of the supraspinatus, that is insertion, or in other words, it is called the enthesis. From here, about 1.5 centimeter, there is the critical zone. This is the degenerative tears occurs here, and there is a myotendinous junction. Traumatic rupture occurs in this place. This is the supraspinatus tendon. Now, I will describe some pathophysiology of the supraspinatus tendon. These are the collagen fibers, orange in color. In a very delicate way, it is arranged, and there is water bubbles. In a very hard way, it is arranged. But after degenerative process is occurring there, the collagen become illy arranged, and there are reduced number of water molecules there. And it is called the tendinopathy. That is, here there is inflammatory process is going on. And when the severe stage, the tendon is ruptured. There is no collagen is there. It is the supraspinatus tear is occurred. Now we will see some MRI images. This is supraspinatus tendon. This is tendinopathy. This is a mild tendinopathy, and this is here, supraspinatus tear is here. Now comes, what are the different types of rotator cuff tendon pathology? The pathology of the tendon is divided into tendinosis and tear. The tears also divided by partial thickness tear and full thickness tear. The partial thickness tear above divided into three types. One is articular-sided partial thickness tear, interstitial type, and the bursal-sided partial thickness tear. We'll see some MRI images of tendinosis. There is three variety: mild, moderate, and severe. It depends on the area. This is mild, the mild tear. You can see this is moderate tear. This is moderate tear, and this is severe tear. The length is more than 2.5 centimeter. It's a severe tendinosis. There are some cystic changes occur. You can see this has some clinical advantages. The mild cystic changes occur in the bone. It is a bit more water is collected here. Why it is so important to see in the MRI? Because if the anchor suture is inserted here, then it will become the loose setting. And if we move the hand, then it will remove from there, and the failure occurs. So before inserting any anchor, we have to see the MRI before doing this. This is another picture of the bubbles, water bubbles, that cystic changes occurs in the bone. This is another feature we usually find not very uncommon. This is calcific tendinitis. So this is this patient usually present with acute and severe painful status, and we have to see the in MRI in a very better way the calcific tendinitis. It is not a degenerative process. Now comes partial thickness tear, very common. This is a partial thickness tear. This is articular-sided partial thickness tear. You can see another MRI view. This is articular surface. The partial tear is here. Yes, this is bursal-sided. You can see this is bursal-sided partial tear. This is bursal-sided partial tear. And this is interstitial tear. You cannot find in arthroscopy the interstitial tear type. So we have to see that what types of tear is. In interstitial tear, you cannot find in the arthroscopy. So you can see this is the interstitial tear. Now comes full thickness tear. It's a very severe form of tear. You can see this in MRI. You can see the full tear. It is small, but it is very big full thickness tear. This is full thickness tear of subscapulary. You can see this subscapular tendon. This is the insertion of the biceps tendon. The subscapular tendon sometimes lies below the biceps tendon. So when the subscapular tendon tear occurs, it removes the biceps to the medial side. So biceps tendon sometimes does not found here. It founds in here. This is the subscapular tendon found in tear found here in MRI. This is biceps tendon group. This is full thickness tear, another MRI feature. This is full thickness tear. So there is massive tear also. When we call it is massive tear, when it involves 2 or more tendons, when its size is more, it is more than 5 centimeter, and associated muscle is found severe atrophy. When there is a grade 3 or 4 fatty infiltration is found, and there is a retraction medial to glenohumeral line, and the distance between the acromion and the humeral, it becomes less than 6 millimeter. Normally it is more than 7 to 14 millimeter. There is another condition we'll found rotator cuff arthropathy, and that is also here. Now we go for the MRI findings of instability. I've already described the MRI findings of rotator cuff tear. Now we will go for MRI findings of the instability. You can see the labrum is divided by superior, inferior, and anterior superior, anterior inferior, posterior superior, and posterior inferior way. The instability can be divided as a non-traumatic or traumatic. The non-traumatic can be congenital. It may be unidirectional or multidirectional instability. The first time it may occur first or acute, or it may be recurrent. There, in instability, we have to concern in MRI, the 3 parts. We have to see the labrum, we see the capsule, and the bony part. Anterior instability, mostly this is the glenoidal labrum, this glenoid, and this is the head of the humerus. This is the part which usually injured. This is anterior inferior part of the glenoid and posterior superior part of the humeral head. This is the injured part. Now comes Bankart lesion. It's the most common type of instability. Humeral head gets dislocated anteriorly and inferiorly. Anterior inferior labrum gets torn, and superior humeral head will impinge against the glenoid. When it relocates, it leads to anterior inferior labral tear. That is Bankart. This is normal position of the EM. This is in X-ray. This is dislocated anterior inferiorly. This is normal findings of MRI. Now this is anterior inferiorly. This is separated. This is called Bankart lesion. In MRI, you can see anterior inferior labral tear. This is fine. This is anterior inferior labral tear. It's a more bigger size, and this is anterior. This is in axial view. Now comes bony Bankart. When dislocation occurs, sometimes it is so forcefully occurs, a piece of glenoid comes out along with the labrum, and it is called bony Bankart. It is much more good way findings in CT scan. So sometimes the fragment is more, and CT scan we have to adjust it by lateral jet operation. So sometimes we usually see CT in CT scan. You can see there's a small fragment, this bony Bankart. You can see in axial view, in the sagittal view, it is a bony Bankart. Perthes. Anterior inferior labrum is torn, but periosteum is intact. This condition we usually call Perthes. This is an MRI of the Perthes. The periosteum is intact. The periosteum is intact, but there is a fracture, bony fracture. This is AMSA, that is anterior labral periosteal sleeve avulsion. AMSA, this is the labrum is torn and periosteum is still intact, and the labrum get bunched like sleeve of the shirt. So it is called AMSA. MRI view, you can see this MRI view. This is MRI view. You can see this MRI view. There is another condition, GLAD, glenolabral articular disruption. What is the peculiarity? The labral tear occurs as well as articular cartilage also separated. This is called GLAD. Now comes Hill-Sachs lesion. There are two MRI view. This is Hill-Sachs lesion, small Hill-Sachs lesion. This is large Hill-Sachs lesion. Usually, humeral head when get impacted with the glenoid, causing repeated irritation and causing a groove. This is called Hill-Sachs lesion. Now comes posterior instability. That means the humeral get impacted with the glenoid in the posterior part. You can see the MRI views that is impacted in posteriorly, and it is due to this the posterior glenohumeral instability occurs. Clinically, sometimes we don't found like anterior not dislocatable, but the main problem is patient complaints of pain. This is reverse Hill-Sachs lesion. This is reverse to it is posteriorly. Impaction is posteriorly with glenoid and anterior of the humerus. So there is another pathological lesion, that is Hagel, that is humeral avulsion of the glenohumeral ligament. That is, you can see the part of the inferior glenohumeral ligament which is attached to the humerus, it is separated and avulsed from the humerus. This is called Hagel, humeral avulsion of glenohumeral ligament. So instability is already described. Now it comes to the conclusion. We should know MRI in MRI anatomy and MRI features in very well. The status of the we should know the status of the rotator cuff and labrum. We should also know the capsule and the ligament description, the status of the bone, if there is any bone loss in the humeral side or glenoid side, and be aware of normal variants and pitfalls. Thank you very much.
Thank you, Dr. Pervez. Dr. Samanta from Kolkata.
Yes.
Yes, hope you are fine. Any question from any of the faculties? Rajeev?
Yeah. Pervez, please stop sharing your screen. Yes.
Yeah.
So any question from panelists, faculty, any of the faculty? So there is one question in YouTube, Pervez. So please describe about rotator cuff injury. So I think they are asking about the component of rotator cuff injury.
The components of the rotator cuff is supraspinatus, infraspinatus, teres minor, and subscapularis. Rotator cuff mostly injured. There is two types of injury. One is degenerative and another is traumatic. The degenerative tear usually occurs in old person and the traumatic is young person. The degenerative tear usually occurs 1.5 centimeter from the insertion, that is critical zone. And I have already shown the pathophysiology of the degenerative tear. Initially, there was the collagen fiber there is a chronic inflammation and therefore tear of the collagen part of the ligaments, and later on the degenerative tear occurs.
Thank you, Pervez. So there is another question. What are the indications of MR arthrogram? So when you plan for MR arthrogram?
Yes, actually, when the 3 Tesla come, the MR arthrogram indication become reduced. But previously, when it doesn't see clearly, then MR arthrogram we usually do.
Actually, MR arthrogram is more or less now obsolete like this thing.
Absolutely. Not
People are not doing the MR arthrogram. Some people in the European countries, they are not doing the MRI for the cuff. They are doing the CT arthrogram. Okay.
Yes.
And the probably now still probably there are 3 indications of doing the MR arthrogram. One, the best indication from MR arthrogram is the slap tear, because even in the 3 Tesla probably you can't diagnose the slap. One thing. Second is probably your Hagel lesion sometimes can be missed even with the best possible MRI unless it is taken in proper views. Because sometimes the Hagel lesion or the your reverse Hagel, these are the 3 lesions probably for those we cannot see regularly. Probably for the you can do the MR arthrogram if you suspect the slap, and probably clinically we don't understand the Hagel or the reverse Hagel. So the one indication probably in my mind still is the slap tear.
Thank you, Swarnendu, for clearing it. I think we can go with our next talk, the portal placement in shoulder arthroscopy, which is very important, by Professor Dr. Hasan Masud from Dhaka.
Pervez, thank you for the excellent, nice demonstration, nice presentation of all these MRI pictures. Thank you.
Thank you.
Good evening. I would like to thank Indian Arthroscopy Society and the organizers for inviting me in this webinar. Greetings from Bangladesh. And especially I would like to thank Dr. IPS Oberoi, Dr. Rajeev Da, and Swarnendu Da. I would be speaking on portal placement in shoulder arthroscopy. So greetings from Bangladesh, and this is my mentor, Professor Young Alri, one of the shoulder giant in the globe. He's from South Korea. So patient positioning first. It is according to the surgeon's preference. He may choose the pitch chair position or the lateral decubitus position. So first of all, posterior portal. It is the primary viewing portal. Instrument approach to posterior glenoid, labrum, and capsule. So first of all, you have to do the marking. So this is a cadaveric model. This is the anterior part of the shoulder. This is the posterior part of the shoulder. For arthroscopy of the shoulder, we mark the scapular spine, posterior border of the AC joint, and the anterior border of the clavicle. This is the lateral border of the acromion, anterolateral and posterolateral corner of the acromion. This is the AC joint. This is the coracoid process. And this is the coracoacromial ligament. So for placement, first we'll place the posterior portal. So for the posterior portal, entry site is 1.5 centimeter inferior and 1 centimeter medial to posterolateral corner of the acromion. But it is written differently in different books. Posterior border is the workhorse portal for shoulder arthroscopy. Posterior portal is the first portal that you would want to make whenever you are starting your shoulder arthroscopy. So different book marked it differently, but generally the soft spot which can easily be located by palpation after marking the surface anatomy. And here the cannula is directed towards the coracoid tip. So we easily can find the soft spot by using the Romeo 3-finger shark test. What is that? The index finger of the same hand as the shoulder being operated on is placed in the soft spot between the clavicle and the scapular spine. The middle finger is placed on the coracoid and the thumb fills the interval between the infraspinatus and pterispinal. This helps the surgeon find the best softest location of the posterior portal. And you can usually rock the shoulder to anterior posterior, just find the glenohumeral joint. And so what is the field of view? From posterior portal, you can see the anterior glenoid, labrum, biceps, the subscapularis tendons, the articular surface, the supraspinatus tendon, anterior subcapsule, glenohumeral ligament, and posterior humeral head. And passage is through posterior 1/3 of the deltoid and an interval between the infraspinatus and teres minor. What are the structures at risk? Though minimal, but we have to know, in quadrangular space, the posterior humeral circumflex artery and axillary nerve. In triangular space, the scapular circumflex artery. Though the both spaces are 7 to 8 centimeter inferior to the posterior border of the acromion. And see here from posterior portal, you can see the tendon of the biceps and the rotator interval and the subscapularis muscle below. And you see when we progress and go to the deep, then we can go to the subscapularis muscle and to the subscapularis recess. And another portal, this is the anterior-superior portal. This portal allows a direct view down the glenoid face that facilitates the excellent visualization of the inferior glenoid while avoiding crowding with the other portals. And what is the entry site? Midway along a line between the anterolateral acromial corner and the tip of the coracoid. And what is the path and orientation? Cannula directed towards the center of the glenohumeral joint. And you can do it by two ways. One is outside in and another is inside out. So see here, it is inside out. First make the posterior portal, then insert the trocar, and through trocar you can introduce a pin or Wissinger rod, and its tip can be felt between the coracoid process and the anterolateral corner of the acromion. Then make a small incision and just forward the Wissinger rod and then place a cannula on the anterior sharp end and introduce it. So what is the field of view in this portal? Posterior labrum and glenoid articular surface, infraspinatus tendon, posterior capsule, glenohumeral ligament, and anterior humeral head. And passage is through the skin subcutaneous tissue, anterior 1/3 of the deltoid and rotator interval. Enters the joint just anterior to the long head of biceps tendon. See, it is the rotator interval. And structures at risk, musculocutaneous nerve. See here, from the posterior portal, we are seeing, and a rod is introduced, and then through the cannula, the probe is introduced to see the condition of the labrum and also condition of the biceps tendon. See, we're pulling the biceps tendon. And then another portal, mid-anterior portal. The entry site is 1 centimeter inferior and 1 centimeter lateral to the infralateral coracoid tip. The portal enters the joint just superior to the cephalad edge of the subscapularis tendon. And best way to do this is by spinal needle. You can see and you can assess and field of views similar to anterior portal. And this portal is limited by the humeral head laterally, glenoid rim medially, the long head of the biceps tendon superiorly, and the subscapularis tendon. So another is superolateral portal described by Lawrenson. Entry site is 1 centimeter lateral to anterolateral corner of the acromion. Enters the joint obliquely directly above the biceps tendon, where it passes the rotator interval tissue. Field of view same as anterior portal, optimal to anterior glenoid neck view. And then the lateral acromial portal, one of the important portal. And entry site is 2.5 to 3 centimeter lateral to the lateral acromial margin and 1 to 2 centimeter posterior to the corner of the acromion. Actually, 3.5 to 4 centimeter lateral to the lateral acromial margin, and subacromial bursa, bursal surface to rotator cuff, inferior acromial surface, subacromial ligament, and acromioclavicular joint and distal clavicle. So this is the lateral portal, and sometimes, as pathology dictates, might need some infrequently used portals. An anterolateral portal of Emal, what is that? 2 centimeter below the lateral edge of the acromion in the prolongation of the anterior edge. And from here, we go medially to the subacromial bursa. And another is anteroinferior portal, what is also called the 5 o'clock portal. Entry site is 2 centimeter inferior and 2 centimeter lateral to the infralateral tip of the coracoid. This portal is also established in an inside-out fashion. And path and orientation. While viewing from posterior portal, direct the spinal needle cannula or Wissinger rod, the portal travels through the subscapularis and the lateral to the conjoint tendon. Both the cephalic vein and the anterior humeral circumflex artery are in the path of this portal, but a blunt passer rod or cannula can effectively push these aside. And another is posterior inferior portal, which is also called the 7 o'clock portal. The entry site 3 to 4 centimeter inferior and approximately 1 centimeter lateral to the posterolateral tip of the acromion. In order to create the portal in the outside-in manner, a skin incision is made 2 to 3 centimeter inferior to the standard posterior portal, with the portal positioned just above the posterior inferior corner of the glenoid and labrum. For the inside-out creation of the portal, the switching stitch should be inserted through the anterior portal, positioned at 7 o'clock, then pushed through the capsule. This is the posterior inferior portal, 7 o'clock portal. It provides access to the posterior glenoid and capsule, and also the glenohumeral ligaments. This portal is created to retrieve loose body and for the fixation of the posterior inferior labrum. And what are the structures at risk? The structures are suprascapular nerve and artery, the axillary nerve, and the posterior circumflex humeral artery. And another is supraspinatus fossa portal or Nepal portal, also called superior portal. Soft spot bounded anteriorly by the posterior margin of the clavicle, lateral by the medial border of the acromion, and posteriorly by the scapular spine. Passes through the trapezius and the muscle belly of the supraspinatus. The structures at risk are suprascapular nerve and artery, located in the fossa approximately 3 centimeter medial to the portal. The Nepal portal is easier to approach to the biceps root. It may be used for lateral end of the clavicle incision. For slab tear repair, there is chance of bleeding. And another is superior suprascapular nerve portal, described by Lafosse. The percutaneous approximately 7 centimeter medial to lateral border of the acromion and approximately 2 centimeter medial to Nepal portal. Approach to suprascapular notch. This is another portal which is called the portal of Wilmington. This is the portal of Wilmington. And what is the access? The location is 1 centimeter anterior and 1 centimeter lateral to the posterior acromial angle. This portal is created while viewing through a posterior glenohumeral portal, and it is placed to allow a 45-degree angle of approach to the posterior superior glenoid. This portal is essential for anchor placement during the repair of slap lesions with a large posterior component. Care should be taken when placing the portal so as not to damage the rotator cuff near its attachment to the greater tuberosity. So the take-home message is the number of described arthroscopic portals for the shoulder has greatly increased as shoulder surgical procedures have become more complex. Before making arthroscopic portals, a thorough understanding of the local anatomy is necessary to prevent damage to neurovascular structures. When making arthroscopic portals, especially if establishing an accessory instrument portal is contemplated, appropriate angle and spacing of the portals are crucial. Thank you.
Thank you, Dr. Hasan Masud. Please stop sharing your screen.
Yes, thank you, Hasan.
Thank you.
Nice presentation. portals. Any clarification anybody wants or any question, Rajeev, on the YouTube, we can help.
First, I would like to welcome Dr. Sachin Tapasvi, our President-elect of Indian Arthroscopic Society. He has joined right now.
Yes.
Welcome, Sachin sir. And there is one question. So,
welcome, Sachin.
How for Dr. Masud? So,
Yes.
stiff shoulder is very difficult to make the posterior portal. So, what are the tips and tricks? Sometimes, if you have a stiff shoulder, a cuff pathology with some adhesive capsulitis, very difficult to make the posterior portal. So, what are the tips?
First of all, the mobilization under anesthesia is done. Then we go also through the lateral portal and also through the superior portal to release the pathology. And another tip is to introduce water into the space so that it can balloon the effect and just dissipate some pressure to separate the tissues.
I think Rajeev, we can. This is a big issue. How to go ahead with this deep shoulder in with this arthroscopic job. Okay. So nowadays there are a few recommendations. Don't manipulate like your before you go ahead. Yes, Sachin, I will come to you.
Yeah.
So
Thank you for an excellent talk. My question to you is that one of the major problems, especially around the portals for the subacromial space, is managing inflow and outflow. So what is your recommendation? What length do you want your portals to be? And do you use cannulas in all your shoulders? And how do you manage the fact that your portal has to be patent if you're not using a cannula, and yet you don't start invading or any form of, you don't take away any of the deltoid, or you don't start using your shaver in the wrong positions?
Yes, Sachin, probably you have joined late. That's why we are already been answering one question.
I'm so sorry.
No problem. Probably this is because of you joined a bit late. There is a question before you ask the questions, like how to go ahead in the stiff shoulder, how to make the portal, what are the tricks?
Yes.
Okay. So this is a big issue, and because arthroscoping stiff shoulder, because problem is that your capsule is thicker than thicker and stiffer than your humeral head, because humeral is already, because of the DCOs, it is already been soft. And sometimes when you go classically in the posterior portal, sometimes you will be making 3-4 holes in the humeral head rather than going into the joint. So there are two tricks of going in the stiff shoulder. One is that you make a bit superior portal, okay, so that you don't go 2 centimeters below and 2 centimeters medial, because the space between the scapula and the humeral head is actually more or less nil. So if you go bit superior, like 1 centimeter down and 1 centimeter medial, from the superior most area, still you can enter. This is one way. And second, you can already mention that you can do some injection of normal saline inside the shoulder. And third thing, probably if it is very steep that you cannot go from behind, you can there is a technique described by Lafos. Okay, that is known as you go from outside in technique. So you go primarily in the subacromial space, you clear that space, and now you create the hole in the rotator interval. So once you create a hole in the rotator interval, then you can go. So it is from outside in technique. So once you make clearance of the rotator interval, from there you can go inside the your shoulder. So these are the 3 techniques that you follow in stiff shoulder. Now I think Dr. Masud, you can answer the questions by my dear friend Sachin.
Yes. Sachin, sir, what was your question? Please repeat.
Yeah, my question was that what is the recommendation of Dr. Masud when using portals, especially for subacromial work? Does he prefer a cannula or does he not prefer a cannula? And if he does not prefer a cannula, how does he manage the portals to be patent so that every time you pass your instruments, you can pass it with the same amount of ease and you don't destroy any of the normal surrounding tissues?
Yes. First of all, I don't use cannula. But second answer is that during making the portal, I first place the spinal needle. When viewing from the posterior portal, I place the spinal needle and then just pierce the capsule also, and sometimes the in a straight direction. And when I just forward my shaver, I don't just oval it. Just in one direction I put it, and then I shave the actually at first nothing can be seen in a subacromial bursitis or impingement syndrome. So
Dr. Masud, I just interfere. Sorry to interfere. The question by Dr. Sachin was that whether you use cannula in the subacromial space, yes or no?
No.
If you don't use, how you be rest assured that every time you go in and out, that you are not injuring the deltoid, and how you make your portals patent that way. This is the question, Sachin?
Yeah, that's right. Correct.
Yeah. So Dr. Masud, you can go ahead.
Yes. Just I put during putting my shaver, I always direct the same direction, and also by seeing through the posterior portal, I am seeing what is the nick in the inside, whether the shaver is going through that nick or not, and also the shaving the inside tissue.
Okay.
Yeah.
So I think probably we are just been mixed with the questions and this thing. I think Sachin is asking how to be sure that every time you are
because
going...
Swarnendu, what happens is that we create the portals, but as the shoulder starts swelling up, then sometimes the skin incision is somewhere else, and the hole that we've made through the deltoid fascia is somewhere else. So I was wondering if Professor Masud has any special tricks to ensure that.
Okay, the thing is that once the shoulder swells up, your skin marking that you have put before you are starting, it doesn't work. Yes. And a problem is that once you go into the extra capsular space, it's more so because it is not then arthroscopy, it is more or less like soft tissue scopy. So that becomes difficult problem. So every time in the subacromial area, I still did. Nowadays, I don't use the cannula. I only use the cannula when I use my biting instruments, like when I take the fast pass or this antegrade sort of pass, then only I take the bigger cannulas. Otherwise, I don't. If I work from the lateral, my instruments go from the lateral, because the lateral part, your deltoid is too thick. From the anterior and posterior and the corners, you don't have to struggle. So when you use your, otherwise the main use of the cannula is that when you pass your sutures, if you catch your deltoid in between the two sutures, then it's very difficult to catch again the sutures to have a proper knot. Otherwise, you will be struggling with the sutures to retrieve. So that is the way I use that. Sachin, how you use it?
Sachin,
so
Masud, definitely Sachin has got a different trick.
No. It's just a couple of useful tricks. One of them is to use a straight hemostat and open up your portal at least 4 times in both orthogonal planes. That's the first thing. And the second thing is take a radio frequency device, and the hole that you make in the deltoid fascia, just gently dab it, the whole, the internal aperture of the deltoid fascia, just dab it with your radio frequency device, so it keeps a very patent hole, and that's a useful trick that one may wish to try.
Exactly. Thank you.
Yeah. So whenever we sit together, it'll be always we will be learning something new from the masters like Sachin. Okay. Yes. Okay, Sachin.
Thank you.
So Rajeev, I think we are through with the Dr. Hasan's lecture. So we can go to the third one. Hello. Yes. So who is on the third one? Hello, can you hear me?
Is it me now?
Yes. Yes, I think.
The first speaker is not here, so I'm probably the next one.
Rajeev, you can go ahead.
Yes. Okay. Thank you.
You are going to talk on the arthroscopic Bankart repair.
Yes, sir.
Okay. So you can share your screen, yeah.
Yeah.
Yeah, yeah.
I'm trying to share.
Yeah, yeah. It's coming. It's coming.
Okay, can everybody see my screen?
Yeah, yeah. It's a whole screen now, full screen now. Okay, go ahead.
Okay. Respected President of Indian Arthroscopic Society, Dr. IPS Oberoi, President-elect Dr. Sachin Tapasvi, Secretary Dr. Swarnendu Samanta, Moderator Dr. Rajeev Raman, and coordinators. First of all, I must thank you for the opportunity to speak in the Indian Arthroscopic Society SAARC shoulder meet here tonight. And it gives me immense pleasure to see so many known faces. And I bring greetings from Nepal. I am Dr. Rajeev Raj Manandhar, and I will be talking regarding the technique of arthroscopic Bankart. Arthroscopic Bankart repair is currently the most utilized technique in the surgical management of symptomatic shoulder instability. The previous speakers have spoken about the indications and the portal placement. So I will go on to the technique. I prefer the lateral decubitus position because of the ability to distract the glenohumeral joint. Continuous traction is also possible in this position, and I am able to freely access the shoulder from all sides, and that is also an important factor. Portal making has already been discussed, and it has great importance in the success of the procedure. So the portals have to be marked prior to the procedure, and I use the posterior portal, the anterior superior portal, and the anterior inferior portal. There are two videos on this on your screen. Please focus on the bigger video. The smaller video is to keep younger surgeons oriented to the OT environment of the procedure. I have tried my level best to sync both of them. So as you can see, we are viewing via the posterior portal, and on the left side of the larger video, a larger picture, you're able to visualize the biceps tendon. On the right side, you have the humeral head. Inferiorly is the glenoid, and straight in front of us, you can see the subscap tendon. The anterior inferior portal is made using a needle. We must try and make it quickly, and the needle is used to assess the portal placement. The portal is usually good when it's made from outside in, because you can control the portal, which gives you better maneuverability of your instruments. And the more lateral the anterior inferior portal is, the easier it is to place the anchors perpendicular to the joint. But then again, it becomes a compromise to reach the inferior portion of the joint. And if the anterior inferior portal is placed more medially, it is easier to reach the inferior portion of the joint, but it's more difficult to place the suture anchors. So that is why the cannula should enter the shoulder immediately superior to the subscap and maybe about 1 centimeter lateral to the glenoid. And as you can see, we passed our switching stick, over that a dilator, and then a 8 millimeter cannula. The cannula has ribbings which prevents the cannula from coming out of the joint when we pass instruments in and out. Next, we make the anterior superior portal, and as you can see, the needle is coming in first. Adjacent to that, we will be passing our switching stick, and this anterior superior portal is usually placed 1 centimeter superior and 5 millimeter lateral to the anterior inferior portal. And over the switching stick, we are passing our dilator and the cannula. Now we are viewing from the anterior superior portal, and we can see the placement of the posterior cannula. Now, as we go on, we go and inspect the anterior labrum, and you can see the labrum has healed medially on the glenoid, and particular attention now must be placed on the glenoid shape. Bankart has classified significant glenoid bone loss as having an inverted pear shape, in which there is significant bone loss. So we must consider looking at the shape of the glenoid. He said in a study of 194 patients, 61% with inverted pear-shaped glenoid experienced recurrent instability. That is the importance of the inverted glenoid. Now, next, I invert a sharp liberator or an elevator along the scapular neck, and I try to peel the structures from the bone. And once the capsule and labrum have been separated from the bone, I try and advance them laterally. So this must be done very meticulously, And I continue to divide the soft tissues till I can see the muscular fibers of the subscap. And after I get a floating labrum, then I'm satisfied. I use a shaver for debridement and a 4 mm round burr. And sometimes even I use RF to complete my debridement. My goal for this debridement is to release all the scar tissue and get a floating labrum. Now, the use of the burr and the shaver on the scapular neck is done to achieve a good bleeding surface for the healing of the capsule and the labrum when I attach it there with my anchors. And I also use the burr to make marks on the areas at 4, 5, 4, and 3 for the placement of my anchors. So this gives me an idea as to where to place my anchors. So here I am using the burr to make marks on where I'm going to place the anchors. Now, this is where the suture anchors are placed onto the glenoid articular surface, approximately 1 to 2 mm from the glenoid margin. You are able to see my fish mouth guide at 5 o'clock. To reach the most inferior portion of the glenoid, I ask my assistant to distract the humeral head laterally and posteriorly. The anchor has 2 vertical lines that mark the eyelet orientation. As the anchor is seated, one must check that the vertical lines are oriented anterior-posterior rather than superior-inferior. This will help. It will basically minimize suture strand twisting. So, yeah, this will basically minimize suture strand twisting when I'm pulling my knot in the anterior-posterior direction. Then I place the drill holes and anchors through the anterior-inferior cannula for the reason the angle of approach to the glenoid is easier. The number of suture anchors that I use varies depending on the size of the labral detachment, but typically I use 3 anchors. And as you can see now, my suture manipulator is coming in from my anterior superior portal. And with the suture, with my suture manipulator, I'm going to pull out one of the threads through the anterior superior cannula, as you can see there in the video. So I've pulled out one of the sutures through the anterior superior cannula with my suture manipulator. Then I'm going to use a suture passer, which is inserted through the anterior inferior cannula. I prefer to insert an anchor, pass the suture, tie it, and then go on to the next anchor. Certain surgeons prefer to insert all the anchors and do the suturing, but I prefer to do this. And I place my anchors from inferiorly to superiorly. And as you can see, the most difficult suture to place is the most inferior because access to the glenohumeral joint here is quite limited. So this is at the 5 o'clock position. The anchor is the 5 o'clock position. I'm trying to take the tissue from the 6 o'clock position. The torn labrum is usually displaced medially and inferiorly. Therefore, I must pierce the labrum with the suture passer. So then when the knot is tied, the labrum will translate superiorly and laterally. This will also bring the labrum above the glenoid articular surface. So what am I trying to achieve? I'm trying to re-establish the labrum as a bumper to restore concavity compression. As you can see, I prefer to use a 90-degree angle spectrum suture passer. And for right shoulders, I use a right angled instrument. And for left shoulders, I use a left angled instrument. The right angled instrument allows me to pierce some capsule and some labrum and advance it so I can clearly see where the tip of the instrument exits, the soft tissue near the glenoid. Then I bring in a grasper and then pull the suture lasso and insert the suture lasso and shuttle it through the labrum and into the anterior inferior cannula. And then I select the suture that does not pass through the labrum because I want the other strand to be the post. This allows me to slide the knots and obtain better knot security. After that sliding knot, then I place a half-hitch throw and use the knot pusher to basically tighten the knot into the joint. And I try to bring the labrum to the glenoid, leaving my knot towards the labral side. I then pull on the post strand while releasing any tension on the suture anchor strand. and slipping the knot and labrum until the labrum is in its desired position and the knot is tied firmly. So as you can see, I am again repeating the procedure. Put my fish mouth there. Again, I'm placing my anchor. I'm going to use a suture manipulator. Pull out one suture strand from the anterior superior cannula. And then take my bite. My favorite method is a simple suture passed once, but occasionally I use mattress sutures by passing twice to get a more effective bumper if needed. So sometimes you might have to take, with your suture passer, you might have to take 2 bites and sort of a mattress in a mattress fashion. So that will give me a bigger bumper. And the amount of capsule and labrum that is taken depends on the pathology present. So that pre-op assessment under anesthesia will also tell us the amount of the pathology and the amount of labrum that you actually want to take. Certain surgeons have different ways to assess the tightness of the capsule. So a mattress suture is also useful to do that. And this is the last anchor that I'm placing at 3 o'clock. So that's the placement of the anchor. And that's the suture passer. I hold it with my grasper, pull it out. It's a repetition of the same procedure. And then put the thread into the suture passer, pull out the suture passer through the anterior inferior cannula. And finally, then I tie down my knot. So you'll see after the final anchor knots are tied, you can see that good bumper there. So it's very important to establish a good bumper and assess your repair after you've finally done it. So this brings about concavity compression, and that leads to very good anatomical healing. So that is my bumper there. So that was my procedure of arthroscopic Bankart. I would like to thank you all for your kind attention.
Thank you, Dr. Rajeev Raj. Any question, Rajeev?
Yes. Oh.
One question.
Rajeev, do you want to add something on that arthroscopic Bankart? Do you do the same way, or you just want to add anything? Sachin?
Yeah, so I think let's get a comment, Swarnendu, from our respected speaker as to what position does he tie the sutures in. So what degree of rotation would he prefer when he's tying the knots of doing his Bankart repair?
I would preferably put the arm. I would test the amount of tension in the capsule. So I wouldn't say I would go to a specific rotation, Dr. Tapaswi. I would test the tension of the capsule. So because if I do too much of internal rotation, then the problem becomes I would get a loss of external rotation finally when the patient goes to play. So in every individual patient, I would assess the tension. I would assess it in different ways. I would do a pre-op and evaluation under anesthesia. Then under diagnostic arthroscopy, I would also test the tension of the capsule. And prior to taking the bite, I have really edited my video, but when I do my surgery, prior to taking my bite, I put in the suture passer and assess where I'm going to take, how much of capsule I'm going to take. So that doesn't I don't decrease the tension also, and I don't repair it in too much of tension also, because that would lead to a loss of external rotation.
So can you please elaborate upon the statement that you just made, that you decide where you want to take your bite? So how do you decide when to go closer to the glenoid or when to go far away from the glenoid? Can you tell us about your assessment, please?
Yes, I would assess looking at the amount of capsule. If there's a very amount of voluminous capsule, I would go away from the glenoid. and take more capsule. If I had less, if I have a very less voluminous capsule, I would stay closer to the glenoid. And preferably, if you really want me to say, I would do it in about 45 degrees of external rotation, approximately.
Okay.
Approximately.
Yeah. Thank you.
What would you have to say, sir? What would you have to say? I really want to hear what you do, sir.
Sorry?
What would you do, sir? What do you do? I want to hear what
so
you
I think
do.
I
Yes, sir.
completely agree with you. You know, the first thing is that as regards tying of the knots, never do them with never do them with too much of internal rotation. I try and prefer neutral rotation because that's where the arm is going to be, and that's going to be your neutral position per se. So I would prefer to keep the arm at neutral position when tying the sutures. And secondly, as regards where do you take the bites in the capsule, I again completely agree with you. It depends upon the quality of the collagen, how voluminous the capsule is, and if you have global instability, if you have something like MDI, where you have a type 3 capsular attachment, then definitely I would definitely add a capsular plication. If not, I would want to take my IGHL into the repair and try and plicate it up and do a north-south repair predominantly. So I would agree with all your points, and very nicely demonstrated video technique as well. Very nice.
Thank you very much, sir. Thank you.
Can I ask a question, Rajeev?
Yes, definitely.
Yes. You have shown in your video that you have put your lower anchor at 5 o'clock position.
Yes, Dr.
5 o'clock or 5:30? 5:30 or 5 o'clock position?
I would say I went to 5:30, about 5:30. 5:30 would be proper.
But you pull the tissue from 6 o'clock position.
I probably pull the tissue at about 6 o'clock. I would definitely, if I put it at 5:30, I would pull it at 6 o'clock. Yes, because I need to bring that inferior capsule up.
Below upwards and medial to lateral. Okay.
Yes. Yes.
Thank you.
Yes.
Can I ask to Rajeev?
Yes.
If when you do a Bankart, if you find the labrum avulsion extends above a 3 o'clock position, would you place anchors above 3 o'clock position as well?
I would be very careful because you have an anatomic sublabral foramen there. So I would not place anchors. If I had a slap tear, I would probably repair the slap tear, but I would not put anchors from 3 o'clock to the slap tear. I would be worried about over tightening the shoulder also. So I wouldn't put anchors there.
Yes.
Yes. Okay. So I think Sachin, we can go ahead with the next talk.
Yeah, I think so. Great talks. Absolutely great talk and great video techniques.
Great one. Great talk. So I will request now to Dr. Jahangir. He is supposed to talk on the arthroscopic superior labral repair.
Yes, sir.
Yeah.
Okay, I'll share my screen.
So by the time, we can talk with Dr. Sonam. Are you there? Is Dr. Sonam?
Yes, I'm just listening. Yeah.
Dr. Sonam, so what is your say on assessing of shoulder instability? So because you in Bhutan, you don't do arthroscopy. So how do you treat these instability cases?
We just do the traditional kind of, if it is a really bad problem, then capsular ship surgeries or something like that. But we are, as you said, we don't do any arthroscopic shoulder surgeries. Yeah.
Yes. So it's an open procedure you do.
Yes.
Okay. So Dr. Jahangir, your screen is not shared. You can go ahead. Yeah.
Okay. Dear friends, colleagues, very good evening. I am Jahangir from Dhaka, Bangladesh. My thanks to Indian Arthroscopic Society Executive, especially President IPS Obadai, Secretary Swarnendu Samanta, and President-elect Sachin Tabaspe, and today's program moderator Dr. Rajeev Raman. Thanks everyone, and I feel proud to become a part of this educational webinar. Now I go to my talks. My talk is arthroscopic superior labral repair of the shoulder. It is one of the common shoulder procedure of shoulder surgery, and which belongs to the shoulder arthroscopic surgery. Before going to details, everyone should know the surgical anatomy of the labrum. That is, it is a fibrocartilage rim attached around the glenoid rim. Thickest portion at the circumference and free edge is thin, and it is on cross section. It is triangular in fashion. It attaches the capsular ligaments and it depends the joint cavity about 10 to 20% for articulation, and it provides a static stabilizer of the shoulder. Every shoulder surgeon should know it carefully because of the diagnosis, treatment of the disease. And for the superior labrum, it is usually 10 or 2 o'clock position if you think clock face, and it is peculiarity that it is loosely attached superiorly than the inferior, and it is less vascular, so it less potential of healing. It is a pay attention to shoulder arthroscopic surgeon who are going to repair the superior labrum, I mean slab lesion. And then everyone should know some anatomic variants which may be confused during the surgery, treat them as like pathology. Such as sublabral recess, it is usually around the 11 or 1 o'clock position, and it is sublabral recess, that is 1 or 2 o'clock position, that is sublabral foramen, and is another common abnormal anatomic variant, that is Beaufort complex, I mean absence anterosuperior labrum, and where the middle glenohumeral ligament is thickened and cord-like structure. You can see easily when it is present during the arthroscopic procedure. And how superior labrum or slab repair occurs. It is common. It is usually traction by twisting mechanism during the late cooking phase of the throwing, and also traction in the from bicep during the deceleration phase when ball is off the hand. And also it may be occur from compression from a fall on the outstretched arm hand or direct fall on the shoulder. It is fall on flexed and forward arm hand. This is the compression, twisting, traction injury causes regular basis the injury of the superior labrum. And usually patient come to us with our hospital or private somewhere with a definite there is a history of shoulder injury and back shoulder pain. Maybe it is posterior or deep shoulder pain. Usually comes to us with a mechanical symptom like popping, catching, locking, especially overhead sports or activity of daily living. And sometimes patients come to us with weakness of infraspinatus or atrophy and some limitation of external rotation. And it is possibly due to the compression of the suprascapular nerve by paralabral cyst. There is no definitive physical maneuver or test which details the clinically it is superior labral or slab tear, but clinical history and some physical examination can assume that it is a superior labral tear. But confirm, we can diagnose by that is gold standard, that is shoulder arthroscopy. You can go by O'Brien test, speed test, and throwing test, and irrigation test. Also, some other tests can be reveal some sorts of superior labral injury like empty can test, full can test, compression, rotation test. In patient, the patient come to me with some history of shoulder injury, is playing during cricket, young player, and I evaluate him to assume the that is he is suffering from superior labral tear. I do O'Brien test and as well as speed test. In this case, in this video, you can see that I think it is a late poking phase injury. Mostly abduction and external rotation type of injury causes injury of a superior labrum. In this video, he is also young cricketer. His type of injury, he shown that his pain is when he throws the ball That means off of the ball. I think it is deceleration phase. Deceleration phase of throwing causes the injury of his labrum. And we also to see the MRI to diagnosis as for the diagnosis of superior labral injury, as we take the history as well as physical maneuver, we can see that is because some types of MRI can lead to some anatomic variants. Like this is the superior labral tear, which is irregular and which is detected laterally and usually more than 3 millimeter. And in case of labral recess, it may be directed towards the medially or smooth margin and less than 3 millimeter. In this patient, you can see that is superior labral, usually mostly posterior variety type. And in this MRI image, we can see that is labral tear with paralabral cyst. Paralabral cyst. Usually, this patient come to us with external rotation limitation and atrophy of the infraspinatus muscle. You can see. And in this video, we can diagnosis as because I have already mentioned that arthroscopy is a gold standard for diagnosis and treatment of shoulder labral injury. So we can see by this video that it is a diagnosis of superior labral, especially I will think it is a type 2 Snyder classification, type 2 superior labral injury. There are 4 variety of Snyder classification, 1, 2, 3, 4, and also mapped all and describe other 3 variety of labral injury. I do not go detail. You can see other portion of the anterior inferior labrum as well as posterior labrum is okay. Only the superior labrum, that is type 2 Snyder type 2 flap lesion in this video. Usually I do the surgery or when patient come to with my most of the surgery, shoulder surgery, I go lateral decubitus position, usually 15-20 degree posterior tilt and 45 degree abduction, 30 degree forward flexion. I always keep the 3 to 4 kg for distraction of the shoulder. And already this procedure in my previous 2 speaker. And portal, usual portal, posterior being portal, and the superior mainly used for the penetration of the labra, anterosuperior labral, anterior in mid-glenar portal, I usually use for the sensor manipulation or other pressure. And sometimes also I do trans-rotator cuff, that is O'Brien portal and portal of Wilmington, when there is this posterior superior labral injury. In that case, I use portal of Wilmington, and also there is Neviazer portal, but I rarely use Neviazer portal, which there is so much complication there. And in this video, I go for a labral repair for my patient. So it takes time to, yes, it is working. That is, initially I debride the day, then divide the last tissue and unhealthy granulation tissue by shaver as well as radio frequency ablator to clean the area, creating a remove all the dead and granulation tissue, fibrous tissue as well, and then use the bar to create a bleeding bony surface for potentiate the healing. And it will take also very much because superior glenoid is thin. I here because very attention to remove small amount of bone and tissue, and the patient come to it long time. I first my foot anchor in the shoulder, that is posterior one. I use usually 2 anchor for type 2 lesion, posterior anchor, and then penetrate by stabilization hook and use, and through the biceps anchor as well as bicep tissue I penetrate, and after removing the through the superior portal and the superior, I tie the knot first posteriorly, posterior anchor, and knot tying. Then I go for yes, it is a knot tying in this way. After knot tying, I then go put my anterior superior anchor. Usually I put 2 anchor for the labrum by ankylosing biceps anchor as well as part of the bicep tendon tissue, and I drill. Now you can see drilling and then putting anchor. You can see by hammering but taping the anchor and remove of the trocar cannula, and I penetrate the anchor and labral tissue, superior labral tissue by stabilizing hook and remove the stabilizing hook, and after and going to tying the knot. Yes, after tying the knot, I use scissor for remove the remaining scissor, and you can see that at the last end stage of the swimmer I completed that, but there is some loose of the superior labrum, but I think it is not no need for some putting an anchor. This is I use only 2 anchor, one anteriorly and one posteriorly and one anteriorly for the type 2 slab repair. So for the labral repair, it is very important post-operative rehabilitation. I follow this procedure for the phase 1, 0 to 4 weeks, arm placed in a sling, range of motion of finger, wrist and elbow only. Phase 2, 4 to 6 weeks, sling may be removed. A safe passive range of motion is initiated. Patient should be refrained from external rotation of abducted arm. And phase 3, 6 to 16 weeks, patient begin active range of motion exercise and progress to resistance activities. And phase 4, that is 16 weeks onwards, a progressive strengthening, sports specific exercise and return to sport or previous activity of daily living. And I say my some question I repaired upon them. I is happy with his labral repair in this patient. Also, this man is also cricketer, and this patient has a traumatic injury of superior labrum. Both are happy with, I think, 1.5 or 2 years after the picture taken the picture year of the operation. All are happy. So in my conclusion, diagnosis of slab lesion can be challenging. There is no specific test or imaging study that is perfect. Clinical suspicion is critical and arthroscopy is the key when clinical situation requires a remedy. Normal anatomic variants can be confused for slab lesion and they must be understood to avoid misdiagnosis and treatment. Post-operative return to activities is gradual and individualized. And thanks for attention.
Thank you, Dr.
Hello.
Yes, yes. Thank you. Thank you.
Thank you.
Thank you. Sachin.
Yeah, please start sharing your screen.
Sachin, you want to tell something or any question?
No, I think excellent talk. Absolutely, it was very nice listening to his technique and very perfectly demonstrated principles. My question to him is that
Yes.
you know, now we've become less aggressive about repairing slab tears. So what typically is your indication, and do you normally give them a trial of therapy or would you straight away offer them surgery?
Yes, sir. When patient, I think patient has not improved more than 3 months of conservative therapy like analgesic and physical therapy, and patient still pain his shoulder during activities of daily living or sports, and he cannot sleep on the on that shoulder and back pain during his activity. Then I go for the surgery, decide both physical examination, then radio imaging, then I decide, yes, I go for surgery because you do not improve more than 3 months have lost your time. Sir, any more? You can add.
No. Yes, Swarnendu?
Yes, the problem is the message should be like that. The slap, mostly you treat like you're conservative unless the patient is forcing you. Because sometimes if you operate on slab, you will burn your fingers most of the time. So unless the patient is really incapacitated in his sports activities, and your MRI picture or your whatever diagnosis you do, even you can do the MR arthrogram, because sometimes even the best MRI cannot pick that. As I told in the primary lecture, sometimes we can have the arthrogram to delineate how much is the slap. Okay, so then only you go ahead. And now for the slap is less is more, because sometimes if you do both you fix in the front and back, then slab becomes tight. In tight slab is a more problem than your actual slab lesion. So don't make it tight. So when we started doing the slab lesion, we usually tied the both front and back. Now the theory is that you just tie on the back side, don't touch the front side. So you keep it loose. Okay. So it is a big topic, but these are the very important few topics as I have found in my clinical practice recently. So I have been less aggressive for the slab, and I have been less fixation technique for the slab, because I have burned many times my fingers with the slab, making it too tight. So if the slab is too tight, probably patient will be in real problem rather than having the slab itself.
Yes, my observation is that if still patient complain pain, I think this is pain due to until the healing of the slab with the bone. When there is healing, there is pain removed. I did my patient complain pain after 6 months. Yes, pain. Then after around 6-7 months, that pain is automatically gone. I think it may be interval healing. When it's completed, the pain will relieve.
Yeah.
My observation.
Jahangir, there's a question on YouTube. How do you decide how many anchor you will use for slap tear?
It depends upon the type of the lesion. When it is only type 2 type of slap tear, then only 2 anchor. I usually single anchor, so 2 anchor is sufficient. When it is associated more an anterior labral tear, when it is associated more posterior labral, then anchor will be more in for the use.
Yes, Rajeev.
Yeah, doctor. We can ask. Yes, please.
Question, because problem is that when we started learning this slab, it was like up to Snyder's 1, 2, 3, 4. Now it has been extended. It was extended to 7. Now it has extended to 10. So there are 10 different types of slab lesion. Okay. So it is Snyder, then Maffei, then it was the modified extended one. So don't be perplexed with all the 10 types of slab. So I think the less is more for the slab. Sachin, am I correct?
Yeah, I absolutely agree with you. I think previously, all these slap tears that used to get picked up on MR scans in patients who were more than 30, 35, 40, all of them would get repaired. But I think we have now become very selective. When we do, you use it for only younger patients. And you should have compromise of their biceps anchor, which is again very important. Yes. And that's what you need to definitely bring out in your clinical findings and your imaging, which is exactly what you have demonstrated in your talk. And you've also emphasized that you normally would give them a good course of rehab first. And if they fail rehab, then you would call them back for surgical treatment. So all surgical principles, both pre and intraoperatively, very well demonstrated and very well emphasized. Great talk. Excellent.
Yes. Thank you, Sachin sir. Dr. Sonam, again, Dr. Sonam, are you there?
Yes,
Dr.
yes.
Sonam, yeah. So how do you address this slap tear in your clinical practice in your country?
Sorry. Am I audible?
Yeah, you are audible, but you are not visible. Please open your video.
Yeah. Okay.
We want to see you. Yeah. Yes.
Okay. Well, this is something which we are not able to actually address because we don't have the expertise. So we've just presumed they are having either rotator cuff or tendinosis and just treat symptomatically. Yeah.
Okay,
it's a more of a conservative treatment at your center.
Yes. Yeah.
Yes.
Yeah.
Because we know that all the facilities are not been available over there. So I think the story is that if the guy is young and he is really having your extreme, there are 5 phases in your list, like your cocking phase. This is known as the cocking phase. If they go in the cocking phase like this one, and he is extremely painful, so then only you're basically, this is the peel off mechanism what the Bankart told us. So that is the peel off mechanism. So in the extreme cocking phase and also in the deceleration phase, there is a pain. Then is throwing athletes will be really, they will be in trouble. So then only probably we go ahead with the surgery. Otherwise, it is mostly conservative. And if we go ahead with the surgery, it is less is more. So I think we are
We
done.
can go with our next talk, shoulder impingement by Dr. Dilshan Munidasha from Sri Lanka, Colombo. Dr. Dilshan, please share your screen.
Hi everyone. I'm joining from Sri Lanka. I must first thank Indian Arthroscopy Association and Dr. IPS Oberoi for giving us this opportunity. And I must also congratulate all the speakers who made excellent presentation today. My task is to talk on shoulder impingement. So I first start with the definition given by Richard Neer in 1972. He made the statement of it can be called as mechanical aberration of the supraspinatus as it passed beneath the coracoacromial arch. But in today's context, it is much more broader, and we have various kinds of impingements. Basically, it can be said the impingement happens between the interaction between the acromial arch and the structures underneath the rotator cuff tendons, subacromial bursa, glenoid biceps, and the proximal humerus. So if you go into literature, you will find various confusing names like subacromial impingement, subcoracoid, primary, secondary, internal, external, all sort of terms. So I would like to simplify all these terms and make it into a very simple scheme. So I have drawn this diagram to show it into 4 categories, 4 major categories: the primary, secondary, subcoracoid, and internal impingement. So I will just briefly go through this, what are the structures, and then it can be easily understood. So primary, I will first take the primary impingement. That is, it further can be divided into two stages, two categories. Primary extrinsic is from the outside, that is due to compression from structures outside, and primary intrinsic is structures within the within the rotator cuff. So let us first see what is primary extrinsic, what are the structures that can bring about impingement, and all the structures outside the rotator cuff, the bursa, the humeral head, acromioclavicular joint, and acromion itself can cause impingement onto the rotator cuff. Whereas primary intrinsic is where you find the subacromial arch is normal. It is some pathology within the rotator cuff itself, maybe as a part of thickening of the rotator cuff, or maybe some deposition, calcium deposition, or enlargement of the bursa. The second group is the secondary impingement. That is not due to any kind of pathology within the subacromial arch or within the rotator cuff, but rather it's due to muscular incoordination around the scapula and shoulder. So I will just briefly discuss a few conditions so that everyone can understand. This is normally a sort of normally anatomical anatomy, and the subacromial space is normal, and it's due to abnormal muscular coordination. The few examples I have written down here: the tightness of posterior inferior glenohumeral capsule, and weakness of rotator cuff and And thoracic, some remote deformities like thoracic spine and clavicular deformities can also bring about secondary impingement. Let me say, take one of the examples of this muscular incoordination, which is called six scapular syndrome, where you find all the structures are normal, but there's some incoordination of the shoulder while the patient is abducting. There is incoordination of the scapular rotation and the humeral elevation. There can be some lag of scapular rotation as the patient starts elevating the arm. Therefore, impingement happens at a stage where the scapula should be rotating and clearing the GT, which is coming and impinging on the acromion. The other condition that I can describe is posterior capsular thickening or tightness. In this, as is shown in this picture, when it is tightened, as the patient elevates the arm, there is less resilience from the back of the shoulder, so that the humeral head is early engaged onto the undersurface of the acromion, causing impingement. Simple stretches like posterior capsular stretch and sleeper stretch can bring about relief to this condition. The other group is the third group is subcoracoid impingement, where the impingement happens not onto the acromion, it is to the coracoid. So this can happen due to some pathology of the coracoid, either due to some fracture or congenital abnormalities, and also can be due to some muscular incoordination as well. And the last group, in this condition, there are some interesting things happening. When the coracoid is impinging on the subscapularis muscle, there's a thing called roller winger effect. In this situation, as it is compressed from anterior, the posterior fibers of the subscapularis fails, and the name coined to this condition is called tuft lesion. There is also this is tensile undersurface fiber failure of the subscapularis. And in this condition, the subscapularis muscle is involved, and all the activities in front of the body are painful, and the tests that are performed for the subscapularis become positive. And the management of this condition includes coracoplasty, subscapularis repair, and rehabilitation of the rotator cuff. And the last group happens at the back of the shoulder, as at the extreme of the abduction and acceleration. The rotator cuff, the back of the rotator cuff, become impinged onto the posterior-superior part of the labrum, causing impingement. So, having learned all these four categories, so I will first, I will now talk on the most common variety, that's the primary impingement, where the patient can present with anterolateral shoulder pain, and their pain overhead activities are painful, and the pain is increased with lying down on that side, particularly at the night. And most of them are racket players and swimmers, and there can be some weakness and loss of arm function, and there can be tenderness. Then you can observe muscle wasting and stiffness, and you can also demonstrate painful arc in these patients. So there are two types of tests that we do in impingement. One is to test the impingement. The other one is to test the cuff. So there are two tests that we commonly perform: the Nias and Hawkins test. And for the cuff, we do this supraspinatus, infraspinatus, and subscapularis muscle test. So, however, none of these tests are pathognomonic. If you test for the impingement, it is a combination of tests that should be positive to diagnose. For example, if you have impingement, it is multiple tests. There's a Hawkins test and painful arc, and also external rotation and at arm by the side should be positive. Investigation, Dr. Pervez has describe for some of the investigation. I must tell that there are no special examination method to identify impingement, because impingement is a sort of dynamic thing. What you really see is the sequelae of impingement or some causative factors. In plain X-ray, you might see some exostosis, and due to chronic impingement, you may see greater tuberosis, cyst, and sclerosis. And similarly, on the undersurface of the subacromial process, you can see some sclerosis, which is also called Sawsill sign. And also superior migration of the humeral head can be observed in plain X-ray of the shoulder joint. And on the lateral X-ray, scapular Y view, one can detect the abnormalities associated with the acromion and the coracoid process. So one of these is depicted here is some there are types of acromion. Commonly type 3 and 2 are associated with some kind of rotator cuff injury as well as impingement. CT scan, I think Dr. Pervez has described this, and it is not much used in impingement. Rather, ultrasound is a very useful tool where you can detect sequelae of impingement, that is full thickness tears and partial thickness tears. MRI is a very useful tool, and it's most sensitive, and it's, of course, it's expensive. I don't want to discuss much about, because Dr. Pervez has already discussed this. And the thing to stress here is not only the investigation, it has to be clinico-pathological correlation, because there is no particular test or particular examination method to identify impingement. When impingement happens, there are stages of development of impingement. There happens in 3 stages, very important to identify, because treatment, the management of each stage differs from depending on the stage. So let me first take the stage 1, where there is edema and inflammation of the cuff, and which is a reversible lesion. And one can observe tenderness over the greater tuberosity of the humerus, and tenderness over anterior ridge of the acromion, and you can demonstrate painful lock. And Neer's impingement is positive, and there is slight restriction of the range of motion. In this situation, the treatment is very simple, and as it is reversible. And patient education is important to avoid overt activities. And physiotherapy modality like electrotherapy, capsular stretching exercises, improving scapular stabilizing exercises, and rotator cuff strengthening exercises can also bring about relief. One can prescribe NSAIDs, and corticosteroid is better, but with the risk of rupture of the tendon. It has been found in the literature that ultrasound therapy is of no use in management of primary stage 1. Stage 2 happens in a bit of a middle age group, where pages between 28 and 40. And it is not reversible by modification of activity, and it has got the signs and symptoms of stage 1 plus soft tissue crepitus. If the patient develops crepitus, that means it has progressed to stage 2, and one can have a catching sensation while lowering the arm from the elevated position, and the limitation of range of motion is much more marked than stage 1. Here, of course, surgeon has to involve to do some soft tissue procedures like bursectomy or release of coracoacromial ligament, which can be done arthroscopically. And stage 3 is the worst stage. It happens relatively older age group. It is not reversible, and it has additional symptoms of limited range of motion is more prominent, and you can observe some atrophy of rotator cuff muscle and demonstrable weakness of abductor and external rotators, and also biceps and the AC joints joint also may be involved in this condition. So management of stage 3 is much more complex, and generally you are advised to observe for 3 to 6 months as a trial. That is not for the thinking that it is going to get relieved over a period of time, as we have already stated that stage 3 is not reversible. But the reason for waiting is there can be associated some other pathology. As I said, there is no particular test or investigation method to detect impingement. So whatever some other condition, you have to give some time to resolve. So if you have waited some reasonable time, some subacromial decompression can be done with dealing with these structures like bursectomy and release of or removal of coracoacromial ligament, acromial resection, and clavicular joint resection as well. So I will briefly tell how it is done. So it can be done at BHR position or in lateral position, and portal placement has been described by the other speaker. And so I will show a brief video how it is done. First you have to do bursectomy, and you have to clear the lateral gutter and the anterior gutter. And first there are some adhesion of the periosteum and the soft tissue adherent to the anterior inferior surface of the acromion, and you may release the coracoacromial ligament at the same time, and then switching between the portals coming from lateral and anterior and anterosuperior. And you start by looking from the posterior, but as you can switch between portals, then you come with the burr to shave off the anterior part of the acromion and shave off the undersurface of this acromion, so making it leveling. And as you go along, so you can see some bone is getting appeared as you shave off the undersurface of the acromion. And that is how you see after shaving, and under the acromion, enough space under the acromion. And definitely sometimes there is associated rotator cuff injuries which you have to deal with after the decompression after acromioplasty. So take home message here is there are about the mostly presented shoulder problem in the outpatient clinic is impingement, and more than 60% can be managed conservative measures, and management depends on the type of the lesion. And this is an area where clinical diagnosis play a bigger role than the examination test, examination methods. And also should not forget that ultrasound is equally effective as MRI. And we must think twice before you give second steroid injection, because repeated injection can cause damage to the rotator cuff itself. So that's all what I have to say in this presentation. Any questions?
I think Dr. Rajeev has exited by mistake.
Yeah, Dilshan, can I ask you a question?
Yes.
Yeah, Dilshan, nice to see you again. This is Sachin Tapasvi. How do you do? Yeah. Great talk and excellent delineation of all the various concepts of how we get impingement. My question to you is a very practical one. Is that how often are you performing isolated subacromial decompression? in your clinical practice?
Depending on the patients, then I have to assess the clinical scenario, the patient's age and the clinical situation. If it's a very old patient and with impingement, very symptomatic, not relieved by conservative measures, then not all cases of rotator cuff are repaired, because one can find that in old age about there's fair amount of patients who have cuff tears without any symptoms. Therefore, depending on the age and the presentation, I take the decision whether to, and the size of the rotator cuff tear, I decide to whether to do repair or just do decompression itself. As
Okay. Swarnendu, any comments?
Just for the singular procedure is very rarely done, unless otherwise there is a type 3 biliary sort of thing. Okay. And thing is that when we started doing your shoulder arthroscopy, every time we are taught like the first step you follow in the subacromial decompression is take off your CA ligament. But this is a big no nowadays. It is, you should not take off your subacromial, your CA ligament that way, because you take off your CA ligament, that is a problem. Okay. So singularly, I rarely do the subacromial decompression, and unless and otherwise, this is your like exchanging impingement along with a type 3 biliary.
Yeah,
Sachin?
I would agree. Yes, I think the incidence of doing isolated SADs has definitely gone down significantly.
Yes.
And my probably indication of doing SADs, when we are doing it with a combination of a cuff repair. So that's probably the only time. I just remember doing maybe one patient in the whole of last year as an isolated SAD alone. Yeah.
But problem is that, to be telling you the truth, when we started doing the shoulder arthroscopy, that was more, because we are in the learning phase. Because that was the only patient they were agreeing to come to me for the shoulder arthroscopy. And we also manipulated that way so that we could do the shoulder surgery. Me, Sachin, and all started together. So probably, Sachin, we will all agree that our initial days, the SADs were much more. Nowadays, we are not doing that way.
True, agree with you. But excellent talk, Dilshan, and very, very well, all the concepts and, the approach very well illustrated. Excellent.
thank you.
Any question? I think Rajeev has gone. Sandeep, or any question on the YouTube or any of the faculty? In the meantime, I can start sharing my screen. Okay.
Sir, start sharing your screen. We don't have, we have very positive comments on YouTube.
Okay, okay. Sachin, I am sharing my screen.
Yes. Yeah, please, please.
So I think we have already been covered most of the thing in the shoulder arthroscopy, starting from your MRI to your subacromial decompression, then Bankart, then slap, and this thing. So Rajeev requested me that probably we can have some video of the how we go ahead, because rotator cuff surgery or the talk on rotator cuff is a big one. We cannot cover in most of the things in rotator cuff. Okay, so I'll be just giving some glimpses of how we do some part of the cuff repair. So nowadays, now the concept is coming that sometimes the cuff is not like a single layer, it's a delaminated cuff tear. So what we do in the delaminated cuff tears. Okay, Rajeev, is it visible, no? Bilal, Sandeep?
Yes, visible.
And you are audible also.
Okay, okay, no problem. Okay. So when we go ahead with your this thing, so when you go ahead with your cuff surgery, never ever go away, just go at the subacromial space and start doing your cuff repair. So you have to go intra-articularly, because this is the advantage of doing your arthroscopic cuff repair, because many things you can miss. And the main thing that you don't do in your mini cuff repair, you don't assess your biceps. Okay, so that is the advantage of doing your arthroscopic cuff repair, that you can see the biceps, you can judge the biceps, you can do the biceps sternotomy very easily. Even you can fix your biceps suprapec or the intra-articular. So this is the way you, once you go ahead, you see and check your biceps, and then we learn how to do the lasso loops from one of the mentors in shoulder arthroscopy, Laura Lafos, that how you go ahead with your lasso loops. Okay, So if you want to save your biceps, so you can do the lasso loop for your biceps. So you put the your anchor just at the where the biceps is exiting, but be sure that the biceps tendon, which is going to be in the groove, that is not being very frayed, or is not lot many synovitis is not there. So that if you see there lot many synovitis is there, then probably you are making, because patient won't be very happy that way, because your that part, because the groove part of the biceps, if the synovitis is there, then this is the according to Lafos, that this is the most most of the nerve fibers are there. Okay, so you can take the lasso loop at the from the one anchor which has been triple loaded. Then you can take another one bite with your spectrum so that you can fix the bicep. Even you see that I have not taken off the biceps from the supraglenoid tubercle. So if you do like that, then you can know that this is the length of the biceps that is there. Okay. So now you take another one simple bite from the biceps. Then once you fix the biceps from the anterior most triple loaded anchor, then you just fix the biceps over there. This is the way how we do it. But most of the time, if I see the biceps is frayed, it has been completely degenerated more than 60-65 years, I will love to do the subpectoral biceps stenosis. Okay, because that is easy. Hardly it will take 5 minutes time at the end of the surgery. Then and the patients are very happy. Okay, so once you fix the biceps, then you can take the intraarticular biceps part of the biceps can be taken off. Another one, when we started doing the biceps stenosis, usually we can take the biceps, one loop in the biceps, we can externalize it, you take off the intraarticular part, and then you can again you can fix it with your screws, your on the intraarticular way. Okay, so once you fix your biceps, then you go ahead with how you judge your cuff. Okay, so this is the way how the biceps has already been fixed with one lasso loop and one simple suture at the biceps. Okay, so this is the way, and I don't take any fancy knots for whatever I do Bankart, I do your when I do your cuff, I always do the alternate half hitches. I'm happy with that. Okay, so this is the way how you can repair your cuff, you check your reducibility. So this is the another one very important point. You have to check the reducibility of the cuff, because cuff should not be should be stitched in tension, because that is the first step that you do wrong, and your 100% if you do in tension, your cuff is going to fail. And this is the way, if you take the magic grasper, you can take the big crocodile, you can see how the calf is sitting, because this is not only tell you how the calf is going to sit, but also this will tell you that what is the orientation of the calf tear, whether it is the L, reversal, U, or the massive U, or the crescent. So then you do the intra-articular release, because it is not only release on the extra-articular part, because you have to do it intra-articularly. And when you release intra-articular, remember, you should not go beyond 1.5 centimeter, because if you go 1.5 centimeter beyond, probably you are going to kiss the suprascapular nerve. So you have to be very cautious. And one thing is that then you have to abrade. Then you have to abrade on the hello.
You are audible, Swarnendu.
Yes, we can hear.
You are audible. We can see you.
Okay.
We can hear you. You can hear you.
The video is stuck somehow. Okay, I am just it is not running. Okay. So then you have to check that the just 1 minute, Rajeev. I don't know how it has happened.
You switch it off and again start.
Okay. Just
close the video file.
Close video and then open it, Swarnendu.
Meanwhile, Rajeev, you can ask the questions. If,
okay, in the meantime, you can take one question. I'll be
asking. Yeah, we can take some question. So, Dr. Dilshan, there is one question. Dr. Dilshan?
Yeah, I can hear you. Yeah,
you can hear. So there is one question on so for shoulder impingement. So your initial treatment is conservative first. Then when do you plan that yes, we should go for an operative procedure?
We have to first employ other measures, that is scapular rehabilitation, shoulder rotator cuff rehabilitation, and NSAIDs, and giving enough time. If there is no relief, if the patient depend on NSAIDs, then we think of, and also our tests are positive and there are telltale signs of impingement. So all come into picture, and so we take a decision depending on the patient's presentation and how much the rehabilitation we have progressed, and then we make a decision. It's a tough decision. I know it is sometimes take longer time, but no harm if the patient can wait for some time.
Okay, Rajeev, I'm just trying.
Yeah,
Okay.
yeah. So we will. Yeah,
Okay.
please, Swarnendu.
So now probably we stopped here. You have to do the intra-articular release. And when you do the intra-articular release, never do overzealous, because if you go beyond 2 centimeter, 1.5, you are going to kiss the suprascapular nerve. Okay. So this is the way how you release. Then you check your reducibility. And when you pass your sutures in the cuff, you have got certain things. Like you can do your antegrade or a retrograde passing things. Okay. So when we started doing your cuff surgery, we usually did with the spectrum. That days it was not there. All these fancy instrument like your fast pass or the fast pass with your grabber. Because when we started doing, it was only the scorpion. Then you have to denude your footprint, because there should be bleeding. Okay. So once you denude your footprint, then only, because this is the area where your cuff is going to heal. Okay. And remember that when you do your medialize, if the cuff is not coming properly, when you do medialize, never medialize more than 10 millimeter, because if you do medialize more than 10 millimeter, is not going to heal. Okay. So then you can use the double loaded anchor, or else you can do the triple loaded anchor, and always use the magic grasper to hold the tissue. Okay, because that it is like the forceps. So you to hold the tissue, you can use the spectrum, you can use your fast pass, you can even sometimes you can use your lasso sort of thing. So many things are there. Whatever is hand, you can use your whatever instrument we use during the Bankart also, that you can use. Okay. So in the corner also, probably you will be using the corners. In the middle, you can use the antegrade pass. Okay. So this is the most of the time the spanning between the sutures is mostly like 5 to 8 millimeter. Okay. So this is the way you take your sutures, and I think more or less every centimeter will dictate that you are probably going to take one anchor. You can take the simple suture, you can take the mattress suture. If the cuff quality is poor, you can take the ripstop. Okay. So this is the way how you take your sutures. Now I am using the spectrum. So also remember that when you do your cup suture, your thing is that you have to be very cautious how you take your sutures, because suture tangling is a huge problem during your cuff repair. Okay, so you have to manage your sutures, and probably the best way to keep the suture safe, the portal where you put your anchors, you retrieve your sutures again from there. So then only you will be not mixing your sutures there. Okay. So you can use the spectrum, you can use the Bartbeak, you can use the lasso, you can use the antegrade. You can now you see I am holding with my magic grasper. Both the hands should be working like this way. Then only you will be taking the bites, because if you miss the deep layer, then you are not doing justice, because sometimes the cuffs are delaminated. Even you can see in the MRI that the cuff is delaminated. Okay. So this is the way you take your sutures there. Then I am passing the relay. And you have to take two different bites, one for the deep and one for the superficial layer. Okay. So then I told you, as I told you, I don't do any fancy knots. I always take the simple half hitches, alternate simple half hitches. And never strangulate the tissue, because you don't have to be very harsh when you tie your knots. Okay. So once you sequentially tie your knots, and sometimes people say that you have to take care of your dog ears. Okay. So this is the way you can tie your sutures, like this way. And if the release is proper, and the release is both way, it is on the superior side and also it is on the intra-articular side. Okay. So once you do your knot tyings like this way, then you can take the one suture. You can take 3 or 4 sutures even just to do your lateral rows. Okay, because sometimes we are if the cuff is well reducible, then you can go with your double row sort of repair. So you have to retrieve the sutures from the different anchors, and you can take 3 to 4 sutures in one anchor lateral row, and then once you take your lateral rows like that way, then you can fix with the lateral row. And when you the another one trick in the lateral row is that you have to clear the deltoid gutter very carefully, because unless you clear the deltoid gutter clearly, you cannot see on the lateral side. Now you see sequentially I am taken one suture, one just I am stopped one suture, and knots, and I am tying the lateral row. Okay. At the end of it, gradually one by one you can tie the sutures, so that now you can see the lateral load is done. Okay, so this is the way how you, these are these few steps of your cuff repair. Thank you.
Thank you, Swarnendu, for excellent presentation. And
yes, Sachin,
we have some question.
Any comment
Sachin,
or
sir, Sachin, sir, please.
Yeah, Swarnendu, excellent demonstration. My question to you is 2 questions. Do you first perform a subacromial clearance, or do you do it after the repair? 1. Second is, what is your sequence? I saw that you passed your sutures from anterior to posterior. What is your sequence of tying knots? Is it again anterior to posterior or posterior to anterior?
Thing is that whether you take the bite from the front and back, that will be dictated by your tear pattern. Okay, so suppose this is the L-type tear, that means you will start from the back side. But if it's a reverse L, then probably you will start from the front side. So your tear pattern will dictate you from where you start your suture taking, and then again your tear pattern will dictate you where you start your knots. So this is the way.
So if you have a crescent shaped tear, what would you pass first? Would you pass anterior or posterior?
If it is a crescent shaped tear, I will if it is not matching on the margin on the articular side, I will just probably 1 or 2 margin convergence if it is not passing. And if it is a crescent shaped tear, probably you can go both way, because front and back. But mostly I do from the back side. I do from the backside, because usually the backside seeing and tying is difficult. Anterior side is visualization is not that difficult. Okay.
And you do your subacromial decompression before or after?
No. I do all my subacromial decompression beforehand, because once I clear the space, I see, and then I do. And I am not very aggressive when I take off my acromion. I am least aggressive, because once I see that both my one of my is the saver, like if I put my saver this way on the acromial side, I check the saver, then again I check the saver, because it is like 4.5 saver. So if both the savers are on the safely and fill the space, I don't go much with the acromion. I just take the anterolateral corner, because that is the impinging area. You don't have to go with your always like a cutting block, whatever we have been taught when we starting doing like, because if you go with the cutting block, probably you take off too much of acromion.
Sure.
And the LAFOS always tells that the acromion never overgrows. It is just because of the traction of the CA ligament, the acromion beaks at the front. So you tack that part only, acromion doesn't overgrow.
So biceps augmentation, Swarnendu, what are your indication? You do in all your cases, or it's for your massive tear only?
No. Biceps augmentation I very rarely do. This was not the part of the augmentation. This is because this is the another one technique, that if you sometimes if you just want to do the intra-articular, you do your biceps anchor first, tie it down, and take off the lizard tail. Okay, because then you don't have to struggle with your biceps length. That is this thing. But if you do your subpectoral, or else if do the don't do the intra-articular, then the best way you take off the biceps, and at the end of your surgery you do your subpectoral. Most of the time I do the subpectoral, because it is biceps is very rarely is frayed, only intra-articular and the groove part is intact. Mostly the groove part is frayed also. When you do your biceps, always with the probe you take your biceps intra-articular and check that whether there is fraying in the intra-articular groove part, and some people are told that is known as the lipstick synovitis, that the biceps is covered by synovium, which is not been seen from the intra-articular part. So you take off that biceps intra-articular, see whether there is lipstick synovitis is there in the intra-articular part. Otherwise, you'll do injustice, because this part of the biceps, which is intra-groove, that is the most nerve endings are most at that part.
Yeah.
Can I ask one question?
Yes, yes,
Yes, please, please.
Yes,
Jahangir.
regarding the initial stage of subacromial decompression, in your case, in every case, you do acromioplasty as well as CA ligament excision or no?
No, no, as I told you, CA ligament should never be taken off during your subacromial decompression in your rotator cuff surgery. Never do that. Because if you do the CA ligament excision, you will be disturbing the ring, because the CA ligament is your superior ring. Understood? Because if your rotator cuff fails, then if your CA ligament is not there, then it will be the first step that your humeral head will be going into the anterior superior escape. So never take down in CA ligament ever in your lifetime.
If it is CA ligament is thickened or calcified as well as anterolateral subacromial spar, that indicates
only take down the anterolateral corner only, and that will be you can see if you take your scapular Y view, or if you check your oblique sagittals. If you check your oblique sagittal MRI pictures, you can know how much is the acromial spar at the front. So you'll never, plus this is a request to all my juniors that never take down the CA ligament, please. Sachin?
Yeah, I agree with you.
So can I ask a question?
I will tell
Yes.
I will tell
Dr. Rajeev?
one story, Rajeev, one story. Once upon a time when I was discussing with Ashish Babulkar, he told that I am the president of the not taking the CA ligament society. So this is a lighter note he told me.
Yeah, Dr. Rajeev, you have asking some questions.
What I was trying to ask is, what are the techniques that you use to mobilize the cuff? Sometimes the cuff is very retracted, and what are the practical tips that you would give us to mobilize the cuff?
Yes, very good question. Because mobilization is cuff is probably the 50% of your cuff surgery. Understood? Because in our country, most of the people, they don't agree for the cuff tear once it is done and diagnosed. Probably they will go for the physio injection and whatever, and they come late, chronic tears. So before cuff tear, always read your MRI in your own eyes, whether it is Goutellier 3+. If it is Goutellier 3+, forget about the cuff repair. Okay. So then how much is the retraction? Probably there are 3 types, that 1, 2, and 3. Okay. So if it is more or less like a 3, then it is a problem. So if it is 2, you can go ahead. Or sometimes even with the 3, you can go ahead, but the cuff should be properly mobilized. Okay. So it both on the top and both at the intra-articular side. As I told you, you have to take off all this tissue, whatever is there on that side. And intra-articular part, you can go ahead with your 1.5 to maximum 2 centimeter, because otherwise you are going to kiss your suprascapular nerve.
Suprascapular nerve, yes.
Always also release your front and back capsule. Sometimes you have to release. This is the technique described by another one mentor, like he was also there in our arthroscopic webinar, is the Buddy Savoy. He told that if it is a massive cuff tear, you release the intra-articular capsular part. See that humeral head is coming and matching at the 6 o'clock position. If you see that humeral is coming down, then only you know that your cuff is mobilized. And then you check your magic grasper that it is coming to the footprint. And you should not do a over tension release repair, and never, if you want to medialize, never go beyond 10 millimeter. So these are the few tricks how you do your cuff. And if the cuff is not very mobile, never do, just for the sake of doing, never do a double row cuff repair. Do a single row, because if you have do a double row, it will be more tension, it will fail. And never take your bites at the musculotendinous junction. Understood? Because if you take the bite at the musculotendinous junction, these are frail tissue, these are going to cut through. Correct, Sachin?
Yeah, absolutely correct.
I think Dr. Jahangir, I have answered your question.
Yes.
Rajeev, any question?
So, yeah, there is one question for Dr. Dilshan here on in YouTube. So, Dr. Dilshan, so role of steroid in your impingement syndrome, shoulder impingement syndrome, and how often do you give it?
I get your question. So, you mean
Steroid?
yes.
Yeah, intra-articular steroid. Yeah.
I hardly give injection for the impingement because the risk of tendon rupture. So therefore, I mostly manage by other means, the NSAID, the shoulder rehabilitation, muscular rehabilitation, that sort of thing. So very hardly I like to give it to subacromial injection of steroid.
I
Sachin,
do
sir,
some.
your opinion?
I do. Yes, Sachin is there. Yeah.
So cortisone, I think it's useful. I use it when I see a subacromial bursitis without a tear. So I find that to be a good modality to bring down the pain. And then once the pain comes down, the rehab is a lot more better. And very frequently, I think I also use local anesthetic block to dissociate and differentiate between pain that may be coming from intrinsic or extrinsic causes. And that also helps us, understand whether surgical treatment is warranted for this particular condition or not.
Yes, I also do inject. I also do inject for this impingement if it is extrinsic sort of thing. But one thing I will request to my juniors and colleagues, before injection, please do a ultrasonography scan. Because if you just miss a rotator cuff tear, even a more than 50% partial cuff tear, you are not supposed to inject. Understood? So please do, even if your MRI is not at hand, please do check that. And if there is extrinsic impingement, it is very, very helpful. And it will,
yes.
Patient will be happy and they will happily do the physio.
I think Dr. Tapaswi is talking about an injection that you give for a diagnostic procedure, not for a therapeutic, right? Just a local anesthetic.
Both for the therapy and both for the diagnostic. I think Sachin also goes for the therapy. Sachin?
Yes.
Yeah, that's correct. Both therapeutic as well as diagnostic.
Therapeutic and diagnostic, both.
Dr. Rajeev, whether you give this steroid with the bony landmarks or under ultrasound guidance? Because nowadays,
yes, ideally you should give it under ultrasound guidance, but due to the lack of ultrasound that due to the lack of the machine or the musculoskeletal ultrasound specialist, we give it most of the time blindly.
I have never injected any of my injection ever with my ultrasound guide.
Yeah.
Because that is time consuming. We don't have that much of time. And the question is that if for the subacromial you don't need it. And for
I absolutely agree with you, sir.
Intra-articular also you don't need it.
Mostly we give it blindly.
You should be happy with that.
Yeah.
You are true expert on that. You can do that happily. Don't involve the ultrasound musculoskeletal guy.
All right, I think we are overshooting the time, and Sandeep is giving red signal that it's 2 hours on more than 2 hours on YouTube. So I think now Sachin sir, please from your side, and then we will have a vote of thanks from Swarnendu.
Sachin is the master of that. Sachin should give the tricks at end of the video.
Okay, so I think if I want to give take-home message and closing remarks, today's combined SAARC meeting was a fantastic session. We had this unique opportunity to hear from our friends of our neighboring countries. All the talks were very well presented. We had a fantastic mix of both key current concept talks, diagnostic dilemmas, how do you take care of them, as well as demonstrations step by step of all the commonly performed surgical procedures. We're extremely thankful to our colleagues to help us and spread the awareness about education, which is one of the key goals of the Indian Arthroscopic Society. And I'm sure we would find that we get more and more participation from your end as well to help us carry forward our basic aim and goal of furthering of knowledge. So thank you so very much to all our friends to participate in today's webinar. And I hand it over to Swarnendu to give his closing comments and announcement of the next series.
Thank you, Sachin. And I thank personally and really from my heart that we are all been now jailed. This is the second webinar from the Indian Arthroscopic Society and all our friends, SAARC countries. And this is, I think Rajeev is the main person, key person who is doing regularly the contacts with the SAARC countries, and he is the key person who is keeping contact with everybody. We have just been helping him. So 3 cheers for Rajeev, and me and the whole IAS EC is behind him just for the support, how we go ahead with your scientific program. So I hand over to Sandeep and Pradeep.
Yeah, Pradeep. Sandeep, please share our future meetings.
Yeah.
Yes.
So dear friends, tomorrow we have very interesting webinar in association with Arthroscopic Society of Nagpur. It's on the simplifying shoulder instabilities. So do tune in tomorrow at 7 p.m. on the same platform. Thank you very much.
Thank you. So Rajeev,
Thank you.
Rajeev,
Yeah.
closing remark, final remark from you.
Thank you, everybody. Thank you, all SAARC members. A special thank to Sandeep and Pradeep. So they make it live without any hitches, and every time they are here for all help. Thank you, Sachin sir, for joining and making the discussion very fruitful. And thank you, IAS. Stay safe, stay well.
Thank you all.
Thank you all.
Thank you.
Stream.
Dr. Shonam, you want to say a few words?